Hello, everyone, and welcome back to Karan Academy. My name is Karan, and today we're going to be talking about prostate cancer. Now, in our last lecture, we talked about benign prostatic hyperplasia, and I mentioned a few key differences between BPH and prostatic cancer. Today, we'll be continuing this and talking about how the two differ, as well as the broad principles of managing prostatic cancer. So, introduction. So, what is prostatic cancer? So, it's the second most common malignancy, second to lung cancer, with an increasing incidence with age. So the incidence at 60 years is at about 20%. It's also the second leading malignant cause of mortality. Risk factors for prostatic cancer is a relatively short list compared to many others. So old age, a family history, and genetic link to certain genes like BRCA2. And I'm sure you've heard of BRCA1 and BRCA2 when talking about breast and ovarian cancer. Very, very important to know that having BPH or indulging in sexual activity are not risk factors for prostatic cancer. I went through some of this anatomy before with BPH, but touching on a few important principles again. With BPH, you have hyperplasia of the transitional zone versus with cancers, where you often have adenocarcinomas of the peripheral zone. Now, why is this important and why is this difference relevant? As we mentioned, because the transitional zone is so close to the urethra, firstly, you're not going to have that, right? So a lot of prostate cancers typically do not present with lower urinary tract symptoms. And that is really, really important. Secondly, because these are two different zones, you can have, and because both of them are relatively common, you can have both of them coexisting. Thirdly, when we examine the prostate, I talked about how you are examining the posterior aspect of the prostate, which is close to the peripheral zone, which is why you are more likely to feel a nodularity if it were to be present in the peripheral zone compared to any other zone, right? And this is good because it's easier for us to pick up these cancers. On the other end, as I said earlier, the peripheral zone is quite far away from the urethra, which is why you almost, in most cases, you don't have any lower urinary tract symptoms or symptoms of bladder outlet obstruction. This is not good because you will be often asymptomatic until it has locally invaded, grown further, and compressed on the urethra. And by the time this is the case, it is often spread elsewhere as well. So again, how will this present? As I mentioned, asymptomatically in most cases, detected on routine screening. As it grows, as I said, it can cause lower urinary tract symptoms, which will be very similar to that of BPH. And I won't go through the specifics, but you can have a read through what you would have and why you would have them. In terms of clinical features, again, it's going to be quite similar, with a DRE often being normal in early stages of disease because the size of the nodule might not be significant enough. And suggestive findings of prostatic cancer on a DRE include localized nodules, prostatomegaly. So even having a large prostate is possibly kind of an amber flag, but having lobar asymmetry is another big one. With BPH, as I mentioned, although you may have an enlarged prostate, it's going to be symmetrically enlarged with smooth lobes, and you're going to lose that symmetry with cancer. So investigations to consider: urinalysis, again, to be performed on all patients with lower urinary tract symptoms because they can often mimic a UTI. Blood sugar levels can also cause things like nocturia, frequency, especially if the patient's diabetic, as most old patients tend to be. Good to check this. An FBE and UEC. A UEC is relevant because we worry about bladder outlet obstruction, reflux nephropathy, eventually causing either hydronephrosis, a post-renal AKI. So all of those things, we want to make sure that the renal function is good. And we can also do a PSA. And I've talked about PSA in both the previous lecture, and I'll touch base on it on the next slide. In terms of imaging, you can do an MRI of the prostate, and this is really, really good for staging the disease, as well as a transrectal ultrasound. You also often do a prostate biopsy, and I've talked about the biopsy in a few slides. So PSA, a few PSA points for PSA. So only do this if you suspect a cancer, if you suspect the patient has long enough to live that we can treat the cancer, and obviously if the patient is eligible for treatment. Do not perform this routinely for lower urinary tract symptoms. Note that PSA is produced by all prostatic cells, not just the cancerous ones, and therefore an elevation may be benign. An elevation above 4 nanograms per ml is linked with an increased likelihood of cancer. A free PSA is also relevant, and the ratio of free PSA to total PSA can be considered sometimes. A lower free PSA level is often associated with prostate cancer. Now, in terms of a biopsy, there are 3 broad types we can perform a biopsy. We can either go transrectal, transperineal, or transperitoneal. The difference between 2 and 3, they sound a bit similar. The perineum is the area of skin between the anus and the urethra, and peritoneal is to the peritoneal cavity, and that's often an anterior incision. We usually try to get a transrectal first. We also use prophylactic antibiotics to prevent prostatitis. Now, why is this something we're particularly worried about with this approach? Well, as you're going through the rectum, it is quite easy for you to introduce foreign bacteria from the rectum, which you know is quite heavily colonized by bacteria, into the prostate, which is relatively sterile. We also extract several cores, and cores are just the type of sample we take. And we assess for neoplastic change in all of them. So we take about 10 to 15 cores, I believe, and we assess for changes. We use something called a Gleason's grade to assess the degree of neoplastic change. So 1 is well differentiated, which is good. 5 is poorly differentiated, which is bad. We then use the Gleason score, which is the sum of the 2 most prevalent Gleason's grades across the core samples. I just realized that typo made everything very confusing. I'll just quickly reiterate that. Gleason score, oh my God. Okay. Gleason's grade is the grade we assign to individual core samples. The Gleason score is based on the most commonly seen Gleason's grade across our sample. So let's say you have 10 cores, for example. The Gleason's grade you see are, let's say, 5 of them have grade 1, 3 of them have grade 2, and 1 of them has grade 3, and 1 of them has grade 4. So the Gleason score in this case is going to be the sum of the 2 most prevalent grades, and that's going to be the 5 1s and the 3 2s. Your Gleason score in this case is going to be 1 plus 2, which is 3. And this score is used to assess metastatic potential. So remember, Gleason's grade is grading, score gives us our metastatic score. In terms of staging, we use the TNM system of classification. So this is a common path topic assessed, not the staging for prostatic cancer, but the difference between grading and staging. So staging is based on TNM, and that stands for tumor, nodes, and metastasis. So how advanced is the tumor? What is the lymphatic involvement? And has it metastasized elsewhere? While grading is meant to grade the actual cells and see how neoplastic they appear to be, which is the Gleason's grade, right? So grade, different to stage. So we can broadly classify them into localized cancers, locally advanced cancers, metastatic cancers. Local cancers are T1 to T2, which are confined within the internal capsule and have obviously no lymphatic involvement, no metastatic spread. If you see an invasion into the seminal vesicle or the periprostatic tissue, meaning the tissue around the prostate, that is going to be a locally advanced cancer. You don't need to know the specific numbers, T3b or T4. Just know that, as the name suggests, if you have growth into the periprostatic tissue, that's going to be a locally advanced cancer. Or if you have lymph nodes that are the proximal lymph nodes within the pelvis. But again, you should have no evidence of metastatic spread. And then metastatic cancer means any met, right? So this can be lymph nodes outside the pelvis, common sites like bones, specifically the vertebrae, or uncommon sites like lung, liver, adrenal gland. All of this is going to be bad metastatic cancer. The management option we pick depends on the stage. So let's talk about what options we have. First is watchful waiting. As I talked about earlier, if you know that the patient is very old and has a life expectancy less than 5 years, the tumor is slow growing, they are asymptomatic, we just watch them and monitor their cancer. What we do is we do scheduled DREs, PSAs, prostate samples often, or imaging through an MP-MRI. The next step up would be active management. Oh, sorry, it's been a long day. Would be active management. So this is very similar to watchful waiting, except if the patient is expected to live on for a bit longer, where we're a bit more intense with our monitoring. So when I say intense, I mean we are checking up more frequently and have a lower threshold to move on to more invasive treatments. This would again be scheduled DREs, PSAs, biopsies, and MRIs. If we do want to pursue therapies, we can firstly start with something called androgen deprivation therapy. As the name suggests, we want to deprive the prostate of androgens. We talked about how the prostate and its growth is driven by testosterone, and more importantly, one of its metabolites called dihydrotestosterone, or DHT. By reducing the total production of testosterone by the testes, we can reduce its impact on the prostate and therefore slowing down the growth of malignant tissue. You can either do this medically using either GnRH, gonadotropin releasing hormone agonists, or antagonists. Now, if you realize the Karan doesn't make sense because we've just said we can use either or. So let me just quickly explain how both of them work and why both of them work. Starting off with the one that's easier to wrap my head around. So the antagonists make sense, right? If you have low levels, or if you block the GnRH receptors, that's going to drop your LH and FSH. That's going to drop your testosterone production. That to me makes sense. The GnRH agonist doesn't make sense because then I think, oh, well, wouldn't that increase LH and increase testosterone? I would be partly right in saying that it would. What happens is, once you give a person a GnRH agonist, you see a short-term rise in testosterone, but what happens is your body very quickly kicks in and starts dropping your LH and FSH to counteract that reverse feedback loop. So if your body thinks, shit, I have too much GnRH, it's going to start dropping FSH and LH, which over a period of time will cause lower levels of testosterone. So those transient levels is something you can see for about 6 weeks. And that's called, it has a name for it, which is fleeting my memory at this point, but you can see a transient rise in testosterone, which is expected and normal with GnRH agonists. In those cases, you can actually use androgenic blockers or antagonists to deal with those symptoms of increased testosterone for a few weeks before the levels drop. You can also do a surgical approach, so a bilateral orchidectomy, or just remove the testes, which is just easier to do. I mean, it sounds easier from a physiological perspective. I'm sure it's surgically hard to do, but you need to know that it increases the risk of osteoporosis because testosterone is good for your bone health. Radiation therapy is the primary treatment option for localized prostate cancers. If that fails, or if the patient is unsuitable or not eligible for active surveillance, we can then move on to a radical prostatectomy, where we take out the entire prostate. Some important complications you should be aware of include erectile dysfunction, urinary incontinence, and infertility. The reason for this is, firstly, you're taking out the prostate, which has a major role in producing a lot of fluids and enzymes from a fertility perspective. You're also removing the prostate, which is very heavily covered with nerves that supply not only the prostate, but also the erectile tissue, as well as supply the bladder quite extensively. So you can end up with both erectile dysfunction and urinary incontinence, which is a big complication, and up to 50% of patients have either or. And lastly, with most of these therapies, you will have a risk of osteoporosis. And therefore, to increase bone health, you want to supplement vitamin D, calcium, regular DEXA scans. Oh, I really am tired. Regular DEXA scans, and also consider osteoclast inhibitors. Osteoclasts, as you know, have a role in breaking down bone. So by inhibiting them, you can actually prevent or offset that rate of buildup and destruction. So if you reduce the rate of destruction, you can help build up healthy bone a bit quicker. And that's all we had for prostate cancer. I hope that helped. As always, any questions, please feel free to shoot me a message or an email. And as always, please look after yourself and please look after your loved ones.